All right. Good morning, everyone. Welcome to another webinar Wednesday here at QLI. I've got myself over here in Studio Q, and Jeff's over there in his office. So we're not too far away. We're close enough to do a presentation together, right, Jeff?
Yeah, I think, Zoom makes that possible. I don't know how far away I'd have to be for that to be unfeasible, but
I know. I do feel like I do miss having you in the studio, though. We'll have to get back to normal sometime soon. So, um, all right. Thank you, everyone, for joining us today. As the slide says that you're looking at and what you signed up for, we're talking about chronic pain today. So we've got Dr. Snell here with me, and if you're a regular to our webinars, that name and voice will be very familiar to you. So, Jeff, as always, I don't know if you can just tell everyone a little bit about yourself before we get going today.
yeah, director of the psychology department here, neuropsychologist by training, been at QLI coming up on 23 years pretty soon. So yeah, quite a run here.
Absolutely, and just such a and you have your hands in a lot of things and a lot of programs here at QLI. So,
Well, I have a lot of interest, and they let me play in a lot of different sandboxes around here, so that keeps me happy.
totally has nothing to do with your expertise and how you've been here long enough to know how everything works, right?
Well, yeah, and I have a key that opens most of the doors around here, so yeah, that's
That's very true. As always, just make sure everyone, if you are looking to receive your certificate of completion, please stick around. We will do a poll question at the end, as well as if you have questions throughout. Use the question and answer, the chat box. We like making this conversational, and I will appropriately interrupt Jeff throughout the presentation if there's some questions that I think need to be answered throughout. If not, we will get to them at the end at a question and answer time. So we've got 220 people on right now, Jeff. And with that, I'll go ahead and, have you kick it off.
excellent. Well, thank you very much, and thank you everyone for joining us today on our topic of chronic pain. So, first and foremost, what's pain? Well, pain is unpleasant. Yeah, I don't think I have to tell anybody that, but it's a really complex and fascinating system that's effective and it's essential. It's necessary. It's a protective mechanism that's crucial to our survival. It's your body's alarm system. It tells your brain when there's danger, actual or potential tissue damage. Now, the interesting thing about pain is that all pain experiences are normal, no matter how crazy that might seem. Walking on a sprained ankle is excruciatingly painful, but if you're crossing the street on that same ankle and a bus is running through the intersection coming right at you, you'll hop, skip, and run out of the way without feeling it until after the fact. In an emergency situation, there are numerous documented accounts of individuals experiencing horrific wounds and being unaware of them in that moment. But in the calm and peace of a relaxing afternoon, bumping a hangnail can suddenly be the center of your universe. If you're old like me, you've reached a point where you can wake up with a sore neck that gets your attention every time you try and turn your head one direction. And for some, looking at a needle when you're about to get a vaccination heightens that expectation and anticipation of pain as opposed to looking away. It's the expectation, it's the anticipation that's a component of our perception and a component of the experience of pain. The more we're consciously paying attention to the expectation of pain, the more things hurt. Pain affects how we move, how we think, how we act, and all those responses are the brain's way of ensuring our safety, to protect us, to help injuries heal. But it's important to note that it's the potential of danger that's more important here to emphasize. The emotional circuits in our brain influence our expectation, and that affects the pain that we, as we will talk about, that anticipation can influence your choices, which over time will limit your actions. And although that's not your intent, it can result in increased perception of pain. Tim, we just had a glitch with our electricity. Am I still broadcasting?
Yep, I was just about to pop on. Yeah, I am hearing you
Okay,
on my
good.
end. I am showing that our internet is maybe not.
Looks like it's stable, so I'm just going to keep right on rolling.
All right, perfect.
All right. So to rephrase, to go back here, what you're going to hear a few times today is that it's the brain that decides if pain is the best response in any particular situation. And so interestingly, that means that even if there are no problems whatsoever in your body's tissues, nerves, or immune system, it'll still hurt if the brain thinks that there is danger. Now, this information here is from Facts and Figures website hosted by the American Academy of Pain Medicine, as well as from the CDC. And it just notes the high prevalence of pain within the American population and the most common types of pain. Back pain, of course, being the most common, and low back pain with the headache being the first two, neck pain being third. Back pain is the leading cause of disability in Americans under the age of 45, and certainly there is a large expense, there's a large cost associated with that. The impact also on quality of life reported. Almost 2/3 of individuals report the impact of pain affects their overall enjoyment of life. And over 3/4 of patients surveyed, 77%, reported feeling depressed. So there is an emotional cost that comes with it as well. 70% report difficulty concentrating, 74% report that their energy level is impacted by their pain, and most notable, 86% of individuals experiencing pain reported an inability to sleep well. So let's look briefly at the distinction between acute and chronic pain, because they're frequently treated the same way, but they're really very, very different, and they warrant very different treatment approaches. Acute pain is an actual tissue damage, something like an orthopedic injury, an overuse injury like tennis or elbow or golfer's elbow, a torn ligament such as an ACL tear, a broken bone, a sprain or a strain like I talked about earlier. Sprained ankle is something that is an acute issue. Like I said, I'm old enough that I can sleep wrong and wake up with a sore neck. That sore neck, after sleeping on it wrong, it's acute pain. It's something that will resolve over a relatively brief period of time. Acute pain is typically defined as something that lasts for less than 3 months, and it also responds well to pain medications. Now, we're going to talk a lot about why certain types of pain medications are ineffective for chronic pain, but it's important to note that I'm not saying that those medications have no use. I'm saying that they are not effective for chronic pain. They are effective for acute pain. If you are going in for surgery, if you have a tooth pulled, if you have any type of surgical procedure done, you are likely to receive medications that are highly effective for treating acute pain following that type of injury. And that's what you want. That's appropriate medical treatment. Chronic pain, though, is not the result of actual tissue damage or injury. At that point, all the tissues are healed. And this can be really hard for patients to understand because they feel pain in that limb or in that part of the body. But just like with a stroke, it's the brain that's driving the issue, not the limb. So the limb, although it's perfectly intact, spinal cord's intact, there's no muscle activation when you have a stroke because the part of the brain that initiates that signal is not firing. If you look at that in the reverse, the other side of the coin is that pain receptors in the brain, when they are firing, causes you to perceive pain, even if the distal receptors in the affected part of the body are not sending pain signals. This is an issue of perception. When it comes to dealing with pain, we do have a lot of tools in the toolbox, and the key to effective and efficient treatment is using the right tool for the right job. They say when you only have a hammer, the world becomes a nail. And that's kind of the situation that we had with opiates for treating pain. If opiates are your primary tool for treating pain, then that becomes the default and it gets used over and over, even when it isn't working. In fact, as we'll talk about, it can actually increase your sensitivity to sensation with a resulting increase in the perception of pain. So chronic pain does not respond well to pain medications or other interventions, things like injections, nerve ablations, stimulators, especially in the long term. And we're going to talk a lot more about why that is. The short answer is that pain is a subjective experience. Now, within the references that are in the end of the handout that we will have for you, Mills and other authors in their 2019 article on epidemiology and associated factors in population-based studies talk about the fact that chronic pain is pain that persists beyond normal tissue healing time and, in the absence of other factors, is generally taken to be about a 3-month span of time. Now, there are many risk factors for chronic pain, including things such as sociodemographic data, psychological functioning, clinical status, and biological issues. So again, it's important to note that the physiological issues associated with pain, the actual tissue issues, are one of many potential factors that can result in chronic pain. Those authors went on to state that chronic pain is a separate condition in its own right, not merely an accompanying symptom of other ailments. And like most diseases, it often arises from a series or combination of multiple events. So that's important to note. Even when there is a solitary precipitating event in the genesis of chronic pain, and that's most often the case with the patients that we see here at QLI, they've had some type of injury that has eventually resulted in chronic pain. Even with that identifiable triggering event, pain is a multidimensional phenomenon. It's comprised of biological, psychological, social, and existential elements. So there's a number of factors and predictors that are associated with the development and persistence of pain. That's why prediction of the development of chronic pain is difficult. It's not just the nature and severity of the injury. 10 people with exactly the same injury, and maybe one, maybe three go on to develop issues of chronic pain. It's also why the treatment of chronic pain can be very difficult. You're not just treating a physiological issue. There are many complicating factors. Of the different factors, health-related behaviors and their outcomes are the most important modifiable risk factors that are associated with the genesis, duration, and impact of chronic pain. That's followed by psychological factors. Now, we're going to start out by focusing on the physiological aspects of the development and maintenance of pain. So how does pain work in the body and how does chronic pain develop? And then we'll address the process of modifying aspects of functioning to best treat this condition. Now, pain and the perception of pain all starts with a neuron. And the pain physiology is a transduction of some signal by the neuron, the receptors, and then it is sent up through the spinal cord to the brain. Now, this is a simplified picture of a neuron right here. And those neural receptors, you'll notice there are different kinds represented. There are mechanical receptors that respond to pinch or pressure, for example. Each of these receptors are very specialized to what they respond to. There are temperature receptors that respond to temperature changes, and there are chemical receptors that respond to chemical compounds, such as allergens or lactic acid, for example. Now, it's interesting to note that none of these receptors are specifically dedicated to pain perception. We do not have a pain receptor. Substantial work in physiology over the years hypothesized the role of pain receptors, but what that work demonstrated was that nociception, or the perception of pain, is reflected by threshold levels of signal and sensitization of signal from these mechanical, temperature, and or chemical receptors. So when these receptors get activated, a message gets sent to the spinal cord where they release excitatory chemicals, which can only attach to specific receptors on the secondary neuron or nerve fiber. So if they fit, it's like a lock in a key. If they fit, they open the receptor and the danger message gets passed on to the brain. If the brain then decides that whatever happened is not a big deal, it'll send down inhibiting chemicals. In this case, the kind of heart-shaped inhibiting chemical, the happy hormone that you see represented there, those are endogenous opioids or serotonin. And in turn, those will activate different sensors, thereby limiting or inhibiting the danger messages. So it dials it down for you. Now, as the message does get passed on through the spinal cord, different areas of the brain get activated. So as the information comes in, the brain is using different areas and cells to try and make sense of the information it has received of this experience and to create a response. The premotor cortex organizes and prepares movements that we need to initiate. Our cingulate cortex is involved with concentration and focus. That's why when you are in pain, it is difficult to pay attention. It is difficult to focus. Our prefrontal cortex is involved with problem solving, with memory, associative areas there. The amygdala is a part of the brain that's really focused on fear conditioning, emotional memory, addiction. It plays a strong role in addiction as well. Our sensory cortex is where that information initially goes within the brain to alert us that our receptors in our periphery have some information for us. All of that information then gets passed to these different areas of the brain that respond or determine on the basis of our experiences and memories and anticipation whether or not should we receive information from our brain that we're experiencing pain and what we should do about it. So all of these different parts of the brain are active in coordinating with each other that information. So, and it's all about the context. So when you look at the cube here, your brain's trying to make sense of the light that's entering your eye and what it knows about the context, the cues that help your brain process this information. In this particular case, where is the light source supposed to be? How does that light and shadow affect the colors? So what you actually see is your brain's evaluation of the object in those colors. And I want you to pay attention to three of the squares here. This top brown square, this middle orange looking square, and this bottom brown square. Now, the interesting thing is those three squares are exactly the same color, but our brain interprets them on the basis of expectation. So let me slide the bottom one up and put it next to the middle one so that you can see that these two are actually exactly the same color. I can also shift a chunk of that middle piece down to match the bottom piece, and you see they are exactly the same color. It's just the expectation of how in shade the brown should be a different color, and our brain interprets that as a brighter color, but in fact it's the same as those in the light. So how does this relate to chronic pain? Well, what I want you to take away from this example is the way your brain may perceive an object or situation may be different than what is actually going on. And that's what's happening in chronic pain. The way the brain interprets an experience or situation may not be an accurate reflection of the state of tissues in the body or what's actually happening within the body. Everything that you perceive and experience is a result of your brain's perceptions. And those perceptions are dependent upon so much more than we are consciously aware of. So it's a matter of context. So let's talk about the underlying physiology that's in action when acute pain becomes chronic. This doesn't happen overnight, but it's a gradual adaptation. Generally speaking, our system becomes more sensitized and therefore more protective. This happens at every level in this pathway, and there are physiological changes that take place, not just in our brain, but within our body as well. What happens at the level of the neuron is input changes. We typically alter muscle activity because of the expectation of pain. So we have a lack of activity, which results in a decreased sensory input from the joints, from the tissues, from the receptors. And because we are trying to override that feeling of threat or injury by not moving that limb as much, the receptors become increasingly sensitized. Our brain responds by increasing a production of receptors, which results in increased sensitivity to touch, temperature, or chemical triggers. So that in something like complex regional pain syndrome, a person can't even stand the pressure, the feeling of wind or shower, or putting a sock on their foot. It's because of a complex interplay of factors, one of which is increased sensitivity at the level of receptors. At the level of the spinal cord, with the increase of receptors in the periphery, now there are more messages coming in and the message is more easily going through. There are also more receptors on the secondary neuron. The brain is being told there's more danger at the level of tissue than there actually is. In terms of pain as a perception based on a gating mechanism, a stronger signal is more likely to be interpreted as pain. It makes sense that there'll be a stronger signal being sent, and that increased sensitivity increases the likelihood of information being received by the brain and being interpreted as a harmful danger signal. So again, we're back to the level of the brain here. With repetitive input, in other words, with continued pain perception, the same areas of the brain get activated over and over and over again, and that route becomes the default network. In other words, the brain itself gets better at perceiving pain and is more easily then tripped. That switch is more easily thrown. So the acute pain is gone, but the brain is still running that network. Another example of this I'm sure you've all heard about is called phantom pain or phantom limb pain. After a traumatic amputation, even though that limb is gone, the brain can still run that same network. That's kind of what we call the dark side of neuroplasticity. Whatever the brain does a lot of, our brain gets better at. With pain, the more pain you experience, the more you perceive, the better the system gets at producing it. It's also why pain medications, nerve ablations, stimulators are not effective in the long run, because our brain can adapt. Our brain has that ability to adapt. So even if there is no signal being sent from the body, if the brain is running the pain network, we feel, we perceive pain. Now, aside from that continuous activation of this network, other changes happen within the brain as well. This is a visual representation called a homunculus, the areas of the cortex of the brain that are dedicated to various body parts. The more sensitive an area is and the more fine control associated with an area, like the hand, the tongue, the more space on the cortex is dedicated to that part of the body. As this hypersensitization occurs, there are changes in the outer cortex that result in, for lack of a better term, smudging, overlapping different parts and functions, thereby making nearby body parts more sensitive. Again, this is another factor when it comes to CRPS where pain can migrate. It can shift from one part of the body to another. You can have a loss of specificity of movement, for example. It can also make that body part more difficult to move. Now, the upside of this is the system is highly plastic. Our brain can adapt. Anything that changes the brain's perception of danger will make the system less sensitive, which will change the level of pain that we perceive. Now, as you can see, this is an extremely complex process happening within the brain. These changes don't happen overnight, and they're not going to be reversed or resolved overnight either. With the hypersensitization of the brain system as well as the emotional connections associated with it, I hope it's becoming clear to you that medical interventions and physical procedures will only have limited or partial effect on chronic pain. Now, I want to look through this briefly. I think this is information that most of you know pretty well because, again, this is something that has received a lot of information over the last several years. The prescribing guidelines published by the CDC in 2016 clearly state the conditions which result in long-term opiate usage should be carefully monitored using the lowest effective dose for acute pain and avoiding extended use. And if you look at that guideline, it says 3 days or less will often be sufficient, and more than 7 days will rarely be needed. Again, this is talking about the fact that for acute pain, opiate medications are the appropriate intervention, but beyond a relatively short period of time, opiates are ineffective for treating pain. These guidelines just came out a few years ago, but they've been adopted relatively quickly. Generally speaking, to get things from bench research or to get things from newly published research into standard clinical practice takes about 17 years. So the fact that these changes have already been occurring rapidly is a dramatic testament to the fact that we are attempting from a medical standpoint to change the issue that has resulted in massive abuse of opiate prescribing and medication use over the past several years. And the reason that came to light, the reason that was so important was because the number of overdose deaths. The most recent CDC information notes 67,367 drug overdose deaths in a single year, which was actually a decline from the year before. That decline in 2018 has been in something that previously was increasing from 1999 up to 2017. Every year, the number of overdose deaths were increasing. But with recent attention being paid and a lot more now information being out there on the dangers of long-term opiate usage, now we're starting to see those numbers drop a little bit. What we are seeing, though, is synthetic opiates now, other than methadone. So fentanyl analogs, tramadol prescriptions, these increased dramatically from 2013 through 2018. So as opiates were starting to be phased out, again, these synthetic and more powerful opiates suddenly became front and center. Because of the massive amount of coverage in the media and labeling this health crisis as an epidemic level crisis, changes have been accelerated. So again, adaptation within clinical practice has been relatively rapid. This is changing quickly, but it hadn't been fully adopted by all prescribers, and the effects of this continue to affect our community. Now, when it comes to things like spinal cord stimulators, there is significant evidence for efficacy of stimulators for failed back surgery syndrome, lumbar back pain, and moderate evidence for high frequency stimulation. But it is transient, and that's the important thing here. When studies have been done looking at how effective a spinal cord stimulator is, they are generally done with 3-month, 6-month follow-up. There is a transient nature of relief. Kumar and other researchers, and that's one of the meta-analyses with positive results that reported in the Pain Physician Journal Evidence-Based Review, they reported their primary outcome of pain relief was achieved by 81% of the cases with implementation of a stimulator device at 12 months. But, and this is huge, this is a big but here, at 24 months, the primary outcome of pain relief was reduced only to 37% of those who had had stimulator implants, and it continued to decline year by year. Again, that's because the brain, which produces our perception of pain, adapts. The dark side of neuroplasticity. So you put in a stimulator, it works for a while, but then the brain, it adapts, it works around it. And so you perceive pain despite the fact that you've had that implant put in. Now, to this point, we focused on the physiological aspects of pain, the reception, transmission of information to the brain that results in pain. But from that pain comes suffering, the alterations to the choices that we make, which can also increase the perception of pain or just reduce our natural activities and engagement that keeps us healthy on a daily basis. Often the anticipation of pain leads to disuse of an affected body part with the resulting deconditioning and abnormal movement patterns that strain other parts of the body. Now, this is generally a decrease of activity level as a whole of the individual. The bigger question becomes for that individual, what have you lost as a result of the pain? What are the things you want to do that you don't do because of pain? This is the suffering that results from not just the experience of pain, but from the anticipation and planning that's involved in avoiding pain or avoiding situations from which pain might be a part. I remember talking with a client one time that we were treating here, and they said, you know, I don't go to the store and shop because I know that if I do that, I'm going to be wiped out for the next 3 days. I'm not going to be able to do anything at all. And so as a result, they had just, their world had kind of closed in to, you know, a couch in the basement, because if I get up and I do anything, it's going to cause me more pain. So I don't do anything. And it's, you know, PTs will tell you motion is lotion. The things that we do in our normal life that cause us to get up and move our joints and carrying laundry up and down the stairs and going out and walking the dog, these are things that are necessary to maintain our health and to maintain between our body and our brain a normal amount of information going in and coming back out. The brain is expecting to get that information from our body, and if it doesn't get it, it turns up the signal. Now, that's important to note because, again, as you see there, that quote, it's important to keep fighting the pain. In a survey that was endorsed by 92% of patients that were experiencing chronic pain. However, it's also important to note that struggling with the pain is the best single predictor of more pain, greater disability. And again, not just in the now, but in the future as well. The expectation of suffering leads to disuse, protection of that body part. The brain responds to that lack of sensory input by increasing sensitivity. It dials up the volume. This becomes a vicious cycle. When we begin to move our body differently, that results in soreness and strains to other parts of the body. And from a psychological standpoint, we begin to incorporate the experience of pain into our expectations, into our sense of self. Our own self-identity becomes, I am a person in pain. It becomes to take a larger role in our life and in our plans. So many things that keep us healthy, emotionally and physically, get pushed aside because of the suffering aspects of pain. So how do you begin to reverse this series of factors that we call chronic pain? Now, I have talked about this one before, and I find this analogy to be very helpful. This is a direct print out of the Butler and Mosley book, Explain Pain. And what they say within this analogy is, by very definition, chronic pain is pain that doesn't go away. They make a distinction between clean pain and dirty pain within that book as well. Clean pain being actual perception of pain, and dirty pain being the suffering that accompanies that perception or anticipation of pain. If you try to solve an unsolvable problem, you get stuck in a game of tug of war. On one side of this chasm is your pain, a monster that pulls with all of its might, and on the other side is an equally powerful entity, and that's you and your problem-solving brain. You're using every bit of strength to pull back. Your chronic pain pulls harder and harder, and it offers you more and more pain. And you pull back using medications and therapies in an attempt to make the pain go away, to beat the monster in this awful game. How long has this been going on? And is there another option? Another analogy that I've also heard that I kind of like is, you're hiking on a trail in a mountain and you come around the corner and a huge rock is rolled down the mountain onto the trail that you're hiking. There's an unpredictable and unplanned interruption there. It's a big boulder and it's not going to go away. I don't think any hiker would think that, well, if I just push and kick it hard enough, it's going to go away. And if I push and kick it and if it doesn't go away, well, I'll just keep pushing and kicking it. It's kind of like the long-term use of medication for treating pain that doesn't make pain go away. It's not an effective strategy. And sitting down and waiting for the rock to go away is probably not going to be really helpful either. You would figure out a way to get around the boulder. You acknowledge that it's there and you make room for it, even if it means going way out of your planned route to get where you want to go. In that case, you're acknowledging the problem, not ignoring it. So again, what they're talking about in terms of shifting the focus is acknowledging that the monster is there, but not letting it drive your choices. This is an important one. What are the things that you value in your life that you would do if you didn't have this pain? Where are you trying to get to? And is it important enough that you're willing to adapt? Is the thing that you value important enough that you would do it even if you have pain while you're doing it? If you had the same amount of pain doing what it is that you most value in your life, if you have the same amount of pain doing that or doing nothing, which would you choose? If you could do what you value, even if you have the same level of pain that you would now, would it be worth doing that? When I've talked with individuals about this and asked, what's the one thing that for you is most important? One that I always remember is a man who said, being a father, I just want to go out and be able to throw a ball with my son. And that was my question. If you could go out and throw a ball with your son and have exactly the same pain that you have sitting on the couch, would you do that? He said, yeah, of course, because it's what I want. It's who I am. I want to be a good father. We know that once individuals start making those changes and engaging in living a valued-based existence, the ultimate result is a decreased sensitivity to pain, a decreased perception of pain, and more importantly, a huge increase in feelings of control and quality of life. Because the issue with pain is not just physiological in nature, it can't be effectively treated just by biological interventions. Again, it is a biopsychosocial event. It describes pain and disability as a complex and dynamic intervention with physiological, psychological, and social factors, and all of these can perpetuate or even worsen one another. That's what we call chronic pain. And what also works is multidisciplinary versus one step beyond that, interdisciplinary. Multidisciplinary is a group of providers working under one roof or within one system. It's fairly easy to achieve. You just get a bunch of providers in one location. It's what hospitals have been for years, right? There's an ease of access improved to the different services that you might need, but they can all still be autonomous entities. In other words, they're not really talking to each other a lot. Interdisciplinary is harder to pull off. This is where the same providers actually work collaboratively together, with the patients benefiting from that combined expertise. Interdisciplinary treatment is not possible in a lot of settings due to third-party billing requirements. This is a point that relates back to when QLI was first incorporated. And again, I bring this up not just to talk about QLI, but to say there are ways of doing things differently than traditionally have been done that actually are of benefit when it comes to some type of treatment, and chronic pain is one of those. When QLI first started as a collaborative effort with the state of Nebraska, from a funding standpoint, probably for convenience and simplification for accounting, that agreement contract was for a per diem-based reimbursement structure. So that daily rate covers everything, not unit service billing. One of the unintended or unanticipated consequences of that was that this model allows for a level of interdisciplinary integration that only exists when you drop unit billing. So if the PT is working with somebody on transfers and I'm working with somebody who is anxious about the possibility of experiencing pain when they do a transfer, I can work directly with the patient and while the PT is working with them at the same time. We can look at physical improvement and the fear and avoidance issues at the same time because neither of us has to flip a coin, decide who gets to bill for that one. We need to adapt our understanding and thinking about pain, not just for our patients, but as a system. It's not a new approach. Holistic treatment programs have existed that address physical, cognitive, and emotional components of a given diagnosis. That's kind of how QLI got into doing some chronic pain work to begin with. This is a model, and I'll talk about this model, that we've used with TBI and SCI patients for many, many years. And there's a strong evidence base for this interdisciplinary approach to improve functioning and treating a person, not just an injury or a diagnosis. QLI is not the only treatment facility that understands and implements this holistic approach, but it's the one that I work at, so that's why I talk about it in particular. We have to pay attention to all aspects of the person. So again, looking at our tri-dimensional program as a model for this, this is how we do it at QLI. Tri-dimensional, if you think of Maslow's hierarchy, the different levels of the pyramid, the first level is really basic health and safety, application of medical care that's needed for the population. And again, as I've said before, chronic pain is not just a medical problem, so you can't just have the base. You have to have the rest of the pyramid as well. The second level is that second dimension is the teaching, repetition of routines that are crucial to neuroplasticity. Our brains change in response to our experiences, and it takes time for those changes to occur. It's not an immediate knee-jerk reaction. So we have to go through repetition of routines to the point that it becomes automatic to develop those functional everyday routines. That increases independence, increases the abilities of our residents, and lastly, it contributes to their sense of self. The bigger aspect of rehabilitation that often gets ignored or minimized, if you're looking at just treating the medical aspects of an issue, but is crucial to developing trust in relationships that support a level of engagement that you need. This is a frustrating process that our patients are going through. And you have to have a sense of purpose associated with the task. Give somebody a task that doesn't make any sense, and it's going to be hard to get them engaged. Give somebody a task that they understand how that fits within their own sense of purpose. If it aligns with their passions, it doesn't matter if the task is fun or easy or difficult or challenging, they're going to do it. Many of the things that all of us do throughout our days and weeks that we wouldn't categorize as fun or easy, we choose to do because they serve a purpose in our life, in our job, in our responsibilities to the people that we love and care about. So we do difficult things despite the fact that they're not fun because there's a sense of purpose behind it. Now, I'm going to speak a little bit more to the aspects of acceptance and what that term means in the context of rehab in a couple of minutes. But, we want to foster acceptance, to instill hope, to restore a sense of anticipation of pleasure. That's what drives this rehab model. This capstone of tridimensional rehab is the integration of things that are motivations and passions within that individual's life and incorporating those things within a person's rehab program. This is where it gets really complicated. You can't just pull a program off the shelf and say, just do this and you'll get better. Because you have to first establish the patient-centered goals and using patient-specific motivations and passions. You have to adapt and change traditional methods to better match the demands of that patient's life. Goals from a functional restoration standpoint are no different than you might encounter in a traditional program from the standpoint of being able to move a limb or degrees of movement or how long you can complete a 6-minute walk in. Time's going to be the same, but let's go with distance in that case. But the process is going to be very different. It's going to be tailored to that patient's life, that patient's values, and that patient's passions. Because that spark or passion is going to be specific to that individual and that person's life, it's got to be an individualized process of rehab. You can't take a manualized series of steps and apply them. A workbook or generalized approach isn't going to be as effective or targeted at an individual. And again, you have to remember that that individual, their psychological functioning, their sense of self, their existential thought processes are important to take into account and to treat when you're talking about chronic pain, because it is a large component. It is the second most changeable aspect of that individual that can be effective in treating chronic pain. First being health-related issues, physiology followed by psychology. And it's important, the further out from injury you get, the more complex recovery becomes. The more need there is to individualize programming and demands to that person's life, to their passions, to their dreams, and to their values. And I put this slide here just to remind you, the complex factors include environment, engagement, satisfaction, active participation. There's a tremendous amount of research out there that supports the notion that just exposure to positive influences, a positive environment, being around happy people tends to make people happier. A conscious attention to positive aspects and expectations tends to change the way people think and predict, expect. These are factors that are associated with decreased stress, improved mood, and direct improvement in measures of cognitive and physical functioning, not just emotional health. Now, in the midst of COVID-19 health concerns, there's also been general additional stress that everyone has experienced beyond just the issues with normal health concerns that folks already have. We already know through extensive empirical data the role that stress plays in compromising our attention, compromising our ability to concentrate at a cognitive level. It also compromises our reasoning, decision-making, and memory. But there's also an increase in physiological effects of increased cortisol levels associated with stress. These result in degradation of our immune system functioning. So being emotionally healthy is a contributing factor to our cognitive and physical health. In any organization, maintaining a positive culture has a direct effect on the bottom line of the organization. And by the way, you also get better productivity and better outcomes as well. Now, psychological functioning. Expectations, assumptions, and predictions that our brain makes play a direct role in the development and maintenance of chronic pain. I want you to differentiate what you think about when you hear psychology and what it means. It's typically thought of as those really difficult cases with lots of emotional problems and chronic mental illness. Pain does not equate to mental illness, and we're not trying to diagnose a mental illness, but you have to address the complex psychosocial aspects related to pain. Pain is a negative sensory experience. That negative sensory experience comes with an emotional response and a reaction, and people naturally respond to pain by wanting to escape it. Pain signals harm or threat, and that's something you want to avoid. With chronic pain, you can't escape pain because it's coming from inside your brain. Sometimes people try to escape pain by retreating to bed or just stopping all activity. But while these strategies, known as fear avoidance, seem like a good idea on the surface, that sedentary lifestyle actually worsens pain over time. It leads to deconditioning, it contributes to depression. So we want to help address all of these things as part of a whole person approach. Cognitive behavioral therapy has strong research as an evidence-based treatment for chronic pain, and it is the only listed approach that is applicable to all types of pain. So the use of CBT in an interdisciplinary team allows us to intervene at multiple points with multiple disciplines. It's supportive and therapeutic, not diagnostic. It addresses the catastrophizing, the necessary acceptance of pain as something that cannot be avoided. It addresses the avoidance of activity, the expectations. And again, looking at and understanding that person through what motivates them, what passions they have, work, family, social, whatever we can to help them understand how to redirect their life and refocus on those aspects that are meaningful. Pain is not meaningful. Focusing on pain is not helpful. Pain has resulted in a loss of meaning, a loss of control. And again, how many doctors have asked you as a patient, what is missing in your life following your injury? Remember that optical illusion we looked at earlier? It had everything to do with context and the fact that our brain uses lots of data, not just physiological internal information, to make the determination as to whether I feel pain at any given moment. Emotional functioning and psychological aspects of an individual are part of that context, and they need to be a part of the treatment program. If you ignore an aspect of an individual that's contributing to the problem, you do so at your own peril. Emotional issues, even if present pre-injury, have the capability to completely derail your efforts of recovery if you're not addressing them. You need to treat the whole person, and leaving a part out is like trying to fix a bucket full of holes. If you leave some of them open, it's not going to work very well. If your goal is to have a functional bucket, you have to patch all of the holes. Now, one of the third wave cognitive behavioral therapies is particularly applicable to the treatment of chronic pain. It's called ACT, Acceptance and Commitment Therapy. ACT is an approach that's based on solid and sound scientific foundation of cognitive behavioral therapy, and it has been demonstrated to be very successful in treating people with chronic pain. It's a mindfulness-based approach, an awareness of the connection between your thoughts, your emotions, your perceptions, and the role that your mind plays in affecting your decisions. Important aspects, particularly when it comes to chronic pain. One is commitment, moving toward valued goals, committing to act in a manner that advances your values in life. Another one is that diffusion piece, the notion that you are not your thoughts. Your brain is a thought-generating engine, but every thought that comes up is not one that you have to connect to unless you choose. So again, ACT is an evidence-based means of treating this. Values, that's an important one. Discovering what's important, what is most important to one's true self, and then taking committed action toward those values, setting goals in accordance with the values and carrying them out. The first focus there on values, that's an aspect of a person's belief system central to the design of a person-centered approach. Every person coming through the door has a different set of motivations, drives, values, history. Identifying those is key to individualizing that program. So a value is an intentional quality that we join together to form a string of moments into a meaningful path. A value is like a direction. You can go east, but you can never get to east. You can have a compass that guides you toward east, and you can travel to a destination in the east, but that direction is not a destination any more than a value is the ultimate goal. We have values that involve choices, not judgments, but choices. With a judgment, you can come up with lots of alternatives, pros and cons. I can go into lots of reasons why I need to buy something, but does that really truly match with my values? Is that necessary to carry out my values? So values aren't goals. A goal is concrete and achievable. It can be a checkbox toward a given value, but it is not the end-all be-all. So values are not in the future. They're always right now. You look at a compass, you can tell what direction you're going right now. and you can correct it on that basis. So it's utilizing and identifying values to make those decisions of what to take committed action for. It's all well and good to identify your values, but if you don't act on them, then they're really not an influencing factor. Looking at a compass won't get you to your goal. You have to get up and move. So moving towards committed action, skills that can be taught. These are traditional behavioral interventions like goal setting, exposure, behavioral activation, things that help enhance and enrich your life, like negotiation skills, time management, assertiveness training, problem solving, crisis coping. Committed action involves setting goals. These are waypoints that let you know that you're getting toward where you want to be. And it's acting even if the actions bring discomfort. There are a lot of things that we're willing to do for those we love that aren't fun, they aren't enjoyable, but they deepen our relationship. They provide support and caring in times when that's needed. Specific to chronic pain, it's acting in a way that's consistent with values that that individual expresses. To achieve the things that are important to them, being able to physically interact with their world often involves pain and discomfort, more so when it's something that they have avoided. But with practice, with repetition, with the development of routines that support that individual's values, they can pursue what is meaningful to them. Now, again, most individuals who are experiencing chronic pain can be effectively treated in an outpatient program. That is the vast majority of how people receive treatment for chronic pain. At QLI, because we are an inpatient post-hospital rehab setting, individuals who come to us tend to be those that have been dealing with this for a long time and have tried everything and nothing has worked. So it's looking at individualizing those programs specific for those folks. Because the process is so individualized, what you're going to do in a specific case depends on that unique person. But it gets people to use their natural motivations and things that are valuable to them. A step in the right direction is starting to put the support in place to get an individual to successfully engage in something that is important to them and to see that they are able to do it, to provide the support that's necessary, and then repeat, repeat, repeat. That's the way our brains change, is we re-experience and re-experience and re-experience. We're working to increase physical activity to send sensation from those perceptual regions of the brain so that the brain can recalibrate, can normalize those sensitivity levels. The incoming signal goes from being a hyperactivation of perception of pain to a more normalized experience. That process takes practice and it relies on extensive repetition and routine to become automatic. Just a little bit about our rehab team. These are the groups that tend to make up. It's a relatively small, dedicated group. It is very interdisciplinary, borders on being transdisciplinary. We all have our specialties, but we also know what other folks are working on. I need to know what the PT is working on. Voc needs to know what psych is focusing on. Nutrition and PT need to be talking to each other. It covers all hours of the day. Somebody's pain may be at worst at 3 a.m. and having someone in an inpatient setting where you can actually address it at that time is an important component for those more severe cases. To provide support, to review coping and compensatory strategies, and help the individual get through the inevitable bumps in the road that are going to come through. This type of programming isn't practical for every case, and I'm not advocating inpatient treatment for every chronic pain case. I'm just talking in this case about the people that we tend to see here that are those more severe. I would say from any program that you're looking at, look for a holistic care program. Because again, for your average case, I would encourage you to seek out those programs that adopt a holistic and person-centered, individualized approach. And just in case you're wondering, this is what our typical program would look like. Medication tapering is important because, again, the presence of that medication in the body actually adversely impacts how chronic pain both develops and is maintained. If you are artificially increasing the number of receptors at the receptor site at the spinal cord level, at the secondary neuron level, or within the brain is going to adapt to that. And that's why those medications are ineffective long term, because the brain adapts. There's also going to be an adaptation as you're tapering medications. The person is going to know you're going to feel more pain as we go through this, but the ultimate goal is to get you back to your baseline level where you were at before all of these issues came together to form chronic pain. And again, it's based on individual goals, interests, and passions, with ultimately getting a person back to life, engaging in their own routines that give them a sense of purpose and meaning, and is part of the process of normalizing the signal between the body and the brain. We want to carry over the progress that they've made while they're here and carry those tools home. It's easy to be upbeat and positive when you're in such an intensely positive and supportive environment, but we want to be helpful with that transition home. That's a huge part of the program. It determines long-term success. And if you take a part out of a machine and you change it and you put it back in the same machine, it's probably not going to work the same. We have to look at education for family, for friends, as well as the patient that we're serving, to incorporate scripts on how to respond. There are routines that have developed over time in response to the chronic pain circumstances. And now that that individual has changed routines, all of the parts around that individual have to change as well. So looking at real life simulation of what life looks like after leaving QLI, and then providing that support and troubleshooting once the person does go back home. We can predict a lot of things that'll come up, but life has a way of surprising us from time to time. So we need a plan B, plan C, and plan D. And so having that not only for the individual, but for also the individuals that interact with that person is going to increase the likelihood of that carryover and success. Now, within the handouts, there are a lot of references, including some that are very, very recent. I have updated the references. Although the references have changed over time, the information really dramatically has not. A multidisciplinary approach focusing on that individual and working to get that individual to utilize things that are important to them, to normalize their day. That's the most important aspect of treatment. Medicine is only a piece of that, and so we need to remember that totally focusing on the medical and physiological issues of chronic pain is not typically going to be anywhere near as effective as looking at the whole person, and it's certainly not going to be effective for those more severe cases of intractable chronic pain that we tend to work with. All right, Tim, I'm going
Awesome.
to wrap up so you can ask a poll question real
Yeah,
quick.
definitely. Yeah. So as Jeff just mentioned, I'm going to go ahead and launch a poll question quick. Jeff did remind me to tell you that there is no wrong answer to this question. We're just kind of curious as to everyone's plans for this year going forward. So that is going to be on the screen right now. Jeff, while that's on the screen, we did have a few questions. If you could talk more or you did briefly touch on this, but how effective is this with CRPS? I know we've had a few folks that have had that as a diagnosis on our campus. If you could just maybe talk briefly about this approach to CRPS and what the success rate has been with that.
Yeah, we've actually had a number of individuals, as you can imagine, with the diagnosis of CRPS, because again, it's a hypersensitivity issue. It's changes within the brain, and it is difficult, certainly, to address because of the level of hypersensitivity that is often present in that case. That, like I said, is something that does not develop immediately. It is not an acute reaction, and it takes time and lots of repetition for that to develop. And so, the time that we spend with someone in a 8-week to 12-week program is not going to fully, certainly I would never claim that we are going to cure anything when it comes to the brain, because again, the brain has the ability to adapt, but it is putting in place the elements that are necessary to renormalize and decrease that hypersensitivity to a point that a person is able to engage in those things that are important, that are meaningful and purposeful to that individual. It doesn't mean that that is going to completely go away. But again, with greater use, with more repetition and routine, what we have seen in those cases is that there is a decrease in that hypersensitivity. The individual is able to tolerate more things that before they simply would not even think of attempting, that they would avoid at all possible costs. Part of it is a trust issue. I can't just go in and say, okay, just start moving it and it's going to be fine, because it takes time and you have to work your way into it. It's like if you decide to go out, Tim, and start running marathons, you're not going to go out and do 26.3 miles the first day. You're going to have to build your way up to it, and it's also going to be painful. There is actual physical pain associated with training at that level, but the people that do it because it fulfills a sense of purpose and meaning for them. If you don't have that sense of purpose and meaning, it's hard to get motivated to do that. Now, again, there was a question earlier too about, changing the shoulder or the muscles. Increasing motion should eventually have that person be able to use their shoulder fully. No, that's certainly not the case. That shoulder might not ever work like it did before. That boulder may not ever be movable from where it fell in the trail. But you're going to develop a way to work around that in a way that doesn't do further damage, to achieve whatever the goal was that fits into that person's values for why they were throwing a ball in the first place, or why that shoulder is moving. So it's teaching a person to achieve their goals and values so that they have a greater sense of personal control, while at the same time going to every degree you can for what physiologically the person is capable of.
Definitely. Yeah, there's a few questions on there, a few that were anonymous, so I won't be able to reach out to you or have Jeff contact you, but we do have a few questions that are rolling through that I do want to make sure we get the right answer to you. So if you could email us at qliwebinars@qliomaha.com, and I can make sure I get those over to Jeff, as well as Jeff's contact information is on the screen. So there were a few longer questions that were probably better for a side conversation with Jeff. And so if you want to reach out to him directly or to me, and I'll make sure those get over to him, as well as we had a few questions about the recording. So if you would like a recording of this, we'll be posting it to YouTube later this week. Just reach out to us at QLI webinars at QLIomaha.com, and we can get that sent over to you. And then let's see here.
Tim, one other thing, because I have updated the references, I'm going to save this as a PDF and send it to you so that you can post it so that folks can have access to it.
Yeah. So once you fill out, if you are wanting a certificate of completion, if you answer the poll question, we'll be sending you an eval. It will be attached to the certificate. Jeff's slides will be attached to that. So you will receive that, a copy of that. So I know we're a little bit over on time, and I want to make sure, Jeff, one, I'm respectful of your time, and two, get everyone else out of here if they have other things. So we appreciate you joining us as always, and be on the lookout for an invite for next month's webinar. We'll be doing our Grit Fit, which is an adaptive fitness program here on campus, as well as talking about Grit Fit. So with that said, I think we'll go ahead and wrap up. There's a few folks still sending some questions. So again, contact us, QLI webinars at QLIomaha.com. And I think that is it, Jeff. Thank you so much.
Yep. Thanks for hosting, Tim. Appreciate it.
Definitely. Take care, everyone.